Okay, hello everyone. This is Jonathan, and I hope everyone is doing well. I am coming to you online this time. Unfortunately, I have to be on call for our lecture for lung nodules and lung cancer. Um, and, this is a really interesting topic for me because the diagnosis of lung cancer and the treatment of lung cancer, the options, this is changing a lot, and it's changing really rapidly, actually, in a way that's hard for me to even convey to you, just like in the slides. I can tell you that, even in the last 5 years, what I would have told someone about their prognosis, what I would have told someone about my recommendation, this has all changed, like almost completely. And so this is really an area where what I tell you today is going to be different in maybe even 3 years. I think there's going to be new protocols. I think there's going to be a real revolution shift in how we approach all this stuff. And what I mean by this is that, um, as you will see, for a variety of reasons, lung cancer has historically been quite challenging. It's a very prevalent cancer because of the prevalence of tobacco, cigarette smoke, and at the same time, it's also had very high mortality related cancer, and this is due in large part due to detection. Right, by the time someone presents with the lung cancer, it's often fairly advanced, and so because of advances in screening recommendations and because of advances in the diagnostic modalities we have, specifically in bronchoscopy, particular types of bronchoscopy, we're now able to send somebody for a biopsy of something at a stage when we really wouldn't have been able to do it even 5 years ago. And when you can diagnose something, not at a stage 2B or 3A or 4, or even when you can do it on a shorter time interval, this has dramatic impacts for people. Okay, so what we're going to do today is we're going to just kind of lay the groundwork. We're going to talk about a carcinoid tumor, which is something that we do encounter, not infrequently in pulmonary medicine. And then we're going to spend the bulk of our time talking about lung cancer or bronchogenic carcinoma. And then we'll talk about lung nodules, these little small solid or semi-solid spots that we find on imaging. And then finally, we're going to talk about hemoptysis. So, I like to really do these types of questions just to kind of lay a little like marker in our brains, right? So this is an example of the type of question that you could expect to see at the level of detail you could expect to see on the pants. So you are seeing a patient with renal stones and a lung mass. If this is determined to be cancer, what is the most likely type? Um, and so this is kind of testing a bunch of different things like, can you distinguish these various cancers and the types of things that they present with? Which of the following is correct regarding how to screen someone for lung cancer? And you can see I've, given you all kinds of confusing and similarly overlapping kinds of definitions. And so we're going to talk about this because screening people for lung cancer properly is really going to be one of the most important things that we can do. And then finally, you send a patient for a CT scan and all of a sudden you see a lung nodule. whether or not this was a screening CT, right? This is just they get some scan, they have a lung nodule. How do you know what to do with it? There's lots of different things, and when you're real quick in a hurry, how do you address that? There's lots of these paraneoplastic syndromes in lung cancers specifically, and you can see here, maybe 15% of lung cancers have some associated paraneoplastic syndrome. Which one is associated with squamous cell? And so this is the types of questions that test writers like to give, because while lots of lung cancers are associated with these paraneoplastic syndromes, there are some subtle and key distinctions about the types of cancers and the types of paraneoplastic syndromes. This is kind of a newer thing that I've started doing. I hope you guys like this, but essentially, I've wanted to start giving you some additional resources, and so one of them, the first one that I'll bring your attention to, is this little interactive website, and you can kind of click through as a patient. It's like that kind of perspective, and it just gives them an idea of like, okay, well, what kind of treatment options might be available, right? This is obviously not a replacement to go and see an oncologist and you get an expert opinion, but it's just a tool, right, that you can give your patients when they want to get information, and they can get good information here. It's not going to give them specifics, and it's not going to enroll them in clinical trials, but this is also not going to offer them healing with crystals or something, right? Like, this is well-researched information. Another one is this website, shouldiScreen.com, which is a tool to assist patients, and specifically it's about screening for lung cancer. And then finally, here's a calculator that we can use to look at these incidental lung nodules. And we're going to talk about both of those tools specifically, but just kind of like when you're coming back and you wanted to look at stuff, these might be helpful places to go back to. So when we begin, we actually begin with something that's a little bit more rare, carcinoid tumors. And what these are is these are rare, but they're fairly slow-growing neuroendocrine tumors that occasionally produce this carcinoid syndrome. Like we see these actually fairly frequently. I don't know that I've ever seen a true presentation of carcinoid, maybe once, but even then it was like, well, was that carcinoid or not? And so what is carcinoid syndrome? Well, it's very distinct, right? It's like this, they get a flush skin, they get this watery explosive diarrhea, and then they become tachycardic and hypotensive. And yes, they get wheezy. I wouldn't even super worry about this right heart failure. We'll talk about why that's on this list of things. Suffice it to say that anytime you have a lung mass, you have the potential to develop right heart failure, as we have talked about in that entire lecture. So, while this is certainly something that could ultimately result from any intraparenchymal lung lesion, this is not the initial presentation. The traditional carcinoid syndrome that I would think of would be like skin flushing, watery diarrhea, tachycardia, hypotension, and bronchospasm. And so, this is really interesting because these tumors can be in the lungs. They can also be in other places as well. And so this is like a preview of what we're going to talk about, but if they have a tumor that's in the lungs, maybe it could cause a recurrent pneumonia. Maybe it can cause coughing or hemoptysis or chest pain. But this is a very vague presentation. Most people, from the time that they even begin to get symptoms until they get diagnosis, is 9 years. And like I said, this is rare, 1 in 100,000, but honestly, there's so many of these that are clinically silent that the true incidence is difficult to know, and most of them are actually just discovered incidentally, right? So a patient has a lung mass that, it's not exactly clear. A biopsy is taken that reveals it to be a carcinoid, right? Or a patient gets an appendectomy, and that appendectomy, is sent for pathology review, and this is what's found. These tumors are typically found in the 5th or 6th decade of life. And so, if you remember from, embryogenesis here, like the foregut, which is where most of these tumors arise from here in the lungs, is but one part. Carcinoids can originate in the midgut or the hindgut. I I don't really know how significant this is. I just know that if you're wondering, like, why in the world, is this carcinoid kind of like rammed in with these other lung diseases in the pulmonary block, it's because we so frequently encounter these as a lung nodule or a lung mass. Okay, and the appendix is actually the most common site of these tumors overall. Okay. So what's happening? Well, a carcinoid tumor, like I said, is this neuroendocrine tumor, and it makes serotonin, 5-hydroxytryptamine, and what happens is then this gets degraded into this 5-HIAA, or 5-hydroxyindoleatic acid. And so this becomes significant because this is actually what we're ultimately testing for. We often don't even do this, to be honest with you, because by the time we find this, a biopsy's already been taken. And so it's actually the release of the serotonin from this carcinoid that makes that carcinoid syndrome. But again, I don't know the incidence of carcinoid syndrome to the number of nodules that we biopsy that become true carcinoid, but I can just tell you that it's like the exception. It's certainly not the rule, okay? So, if you did want to test for this, you could test the urine, and you can test for this metabolite, 5-hydroxyindoleatic acid, or HIAA. There are other tests as well. This tumor marker, chromogranin A, it's sensitive and specific. Of course, taking a biopsy is helpful. And then, if somebody was presenting with hemoptysis, say, for example, then we're going to talk about that in a second, but we might do a CT angiogram. We could also do octreotide scintigraphy, which favors uptake into carcinoid tumor. I don't know that I've ever ordered this or seen this ordered. We did have one case, actually not that long ago, that was unclear, what is this going to be? And I had even suggested this. I just happened to be aware of it, right, because I lecture about this so often. And it was just kind of, it was like a lot of head scratching. Like, I guess we could, I don't know how to order that kind of thing. So, this is something that is certainly true. It's just, I don't know that it's done that often. Because, by the time a biopsy is taken, that's what's a definitive diagnosis. So there's some things you can tell patients with true carcinoid syndrome is to avoid the kind of foods that are most likely to precipitate, right? So these foods that are high in amines, like smoked meats and alcohol, are the most likely to lead to the production of those symptoms. And, you can put somebody on serotonin receptor antagonists, and you could put them on bronchodilators and somatostatin analogs, and I don't honestly know, as I think about this, that I've ever really seen someone get put on chemotherapy. I mean, the book says that this is a possibility, but I don't know that I've ever really seen that. And then, yes, in some cases a surgical resection is possible, but often these are just monitored and not touched, to be totally honest with you, because carcinoids, tumors, they tend to be quite vascular, and they tend to bleed very readily. So the take-home message here is that if you're taking the test and you see a patient that has this weird, they're flush, they have diarrhea, and they're wheezing, they want you to think it's a carcinoid syndrome, okay? And so then you could think about these things like serotonin antagonists and putting them on bronchodilators and, avoiding foods high in amines and all this kind of stuff. So that's a carcinoid. Now we can get into lung cancer, which lung cancer is obviously, a very significant cancer. Bronchogenic carcinoma just refers to any neoplasm, right, that arises from the lungs, the airways, this lung parenchyma. And the primary distinction that we make here is about whether the type of cell that it originates from is what we call a small cell or a non-small cell. Now, non-small cell lung cancer is by far the most common subtype. Non-small cell lung cancer accounts for maybe 85-90% of lung cancers. And so you can see I've kind of listed out the three most common ones: adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. And these are all most common, most often seen in smokers over the age of 65. And small cell lung cancer, which accounts for the other, maybe 15% or so of lung cancer, is also associated with cigarette tobacco use. There is a rapidly evolving body of literature about the specific genetic subtypes and tumor markers and the types of defects that are leading to the development of these various types. Lung cancer certainly does occur in non-smokers. It is far less common, of course, and when it does, it seems that it is actually its own separate and distinct entity that has its own separate and distinct types of insults that may or may not respond to chemotherapeutics in the same way. And so, here is just kind of like a broad overview where we have adenocarcinoma, squamous cell carcinoma, small cell carcinoma, and large cell carcinoma. These account by far for the vast majority of lung cancers. You can see 40%, 30%, 15-15. And so, just to give you an idea, adenocarcinoma is arising from the mucus cells, and it tends to be these little peripherally located tumor. It is the most common subtype that we see in women, and it's also the most common subtype that is seen in non-smokers. So if you recall, I said, non-smokers also get lung cancer, and it's its own distinct entity. And so even the adenocarcinoma that we see in smokers, which is associated with cigarette smoke as well, of course, it's the most common overall. The types of mutations and deletions that we see, they are actually, it seems like, this is an active area of research, but it seems like this is a distinct entity, okay, that will require most likely, genotyping, and very individualized types of patient care. And there are specific ways that lung adenocarcinoma can be subtyped. I don't think that is really, to be honest, like the level of detail. It's just like something to understand that historically we would just say it's small cell or non-small cell. That's not sufficient, right? Now we don't just even say it's an adenocarcinoma, which is a non-small cell. We want to, get really out into the weeds, specifically understanding what the subtype of this is, and in many cases, what are the genetic markers at play here, right? So we're probably very familiar with using these markers, these tumor markers, to help us tailor therapy in the treatment of certain types of breast cancer, right? So we may be familiar with like the types of like HER2 screening and things like this. This stuff applies in lung cancer, but like it's just not quite to that same level yet. It will be in like 15 or 20 years. This will be far more individualized, okay, and there will be far more tailored therapies for the specific genotype. Now, the next most common is squamous cell carcinoma, and this was previously called epidermoid cancer and carcinoma. And these, as opposed to being a little peripherally located lesion, these are typically these like big, large, centrally obstructive endobronchial masses, right? So this is the one that's, this large, mass that's maybe compressing the carina, or, it's invading its way into the, pulmonary artery, things like this. And this is, as opposed to being these little mucus cells, this is a malignant epithelial tumor. And just a kind of a pathognomonic thing. These cells form these little intracellular bridges. And next we have small cell carcinoma. Small cell carcinoma is a it was formerly called oat cell. I don't know that I've heard anybody call it oat cell carcinoma in a long time. And this is really more of this like neuroendocrine tumor, okay? And the pathognomonic thing is like when they describe this salt and pepper chromatin. This is the most aggressive type of lung cancer, and by the time they're diagnosed, typically and historically, they're widely metastatic already. Now, then we have large cell carcinoma. Large cell carcinoma is also known as undifferentiated. This is kind of similar to small cell, right? It's this somewhat of a malignant epithelial cell. It tends to grow and spread really quickly. And it is named this way because they have these really big nuclei. So, this distinction of saying small cell versus non-small cell used to be enough. That would be how treatment decisions were made. But that's not the case anymore. Now we need to know the subtype, but then also like the specific, genetic markers for each one of those. Now, diagnosing lung cancer is tricky because many people, when they first get an abnormal imaging study, whether it's a chest x-ray or a CT scan, they're completely asymptomatic, right? So you can see fully a quarter of people here are asymptomatic, not really showing anything. And as we get more into the future of medicine and the screening for lung cancer is more widely adopted, this is going to be increasingly true, right? A patient is going to have a silent, very small nodule that needs to be biopsied that will ultimately be diagnosed as a cancer, much in the same way that, a patient that has an abnormal result on a pap smear, or a patient that has an abnormal mammogram, or they have a polyp on a colonoscopy. Like, these things are completely clinically silent because the cancers are caught so early that they're not producing widespread symptoms. Now, when we start to get symptoms, we can relate it to the type of symptom that it causes, right? It can either cause a symptom related to the pulmonary lesion itself. It can cause a symptom because it's spreading within the thorax. It can cause a symptom as it's spreading outside the thorax, or it can cause these paraneoplastic syndromes, which are very common and they're very commonly tested. Now, when a lung cancer patient begins to experience lesion-specific symptoms, right, the most common thing is often described as cough. Now, of course, very often these patients have an overlap with lung disease. Occasionally they can present with hemoptysis, and often they might even present being short of breath, and this could be for a lot of reasons. They could have airflow limitations, they could have underlying lung disease, they can have atelectasis, they could have pleural effusions, and you can see up to 15% of patients with lung cancer will get a pleural effusion like this. Still related to that lesion, if we get prolonged hypoxia, patients will potentially develop this clubbing. And we can also see patients present with these recurrent pneumonias, what we call post-obstructive pneumonias, where, there's this cancer tumor that's sitting in there and it's blocking the airway. And so the normal, cilia that are, getting things out of the airway, right, by brushing with those little hairs, they can't effectively clear it. Okay. And he can have he or she could potentially have chest pain occasionally. Like, this is kind of a variable thing, and that could be related to a variety of things. Like, it could be related to a specific develop of kind of fibrotic tissue related to an effusion. It could be related to bony metastasis. It could be related to the lesion itself. It's kind of difficult to say here. And, as that lesion then begins to move and it starts to spread, not just confined into the pulmonary cavity, but into the rest of the thorax, we can start to see other types of things. And so, like, here's a very classically associated thing, what's called SVC syndrome. And, if we recall, the vena cava is what's returning blood into the right side of the heart. And if there's some sort of narrowing at that point, so maybe this tumor is like compressing onto the superior vena cava, then they're going to have impaired return to the right heart. And so they get this facial swelling, fullness. They'll have like an upper extremity, like their arms will be like really puffy, and then they can develop these like prominent chest vessels. This is like very real. I see SVC syndrome quite often, or it feels often. It's just it is significant and very obvious when you see it. Lung cancer patients can develop hoarseness. It's kind of difficult to say because these are smokers. They can get laryngeal cancer, but whenever we get involvement in this recurrent laryngeal nerve, then we can also have changes in our voice. Okay. If I get a tumor that's sitting way up high in my chest wall up here, occasionally I can get this erosion and into this like this bundle of nerves, and it causes this very like unusual constellation of symptoms. It causes Horner syndrome, which we might remember is meiosis, ptosis, and anhidrosis. But then it's also impairing the sending of the signal into the muscles of the hand and the arm. And so because that's happening, we're kind of just having like a muscle loss and wasting unilaterally. And then we'll get this unilateral shoulder and arm pain on the affected side. And so, again, this lesion is like kind of eroded its way into not just the brachial plexus, but this cervical sympathetic nerve. And this does not have to be like absolute, right? Like, just because somebody has like a large apical tumor, maybe they don't have true Horner syndrome, right? They're not getting that full constellation of symptoms, but maybe they do start to get this like shoulder and arm pain. They start to get this atrophy unilaterally. Those are absolutely things that I've seen. Okay. Again, as it's spreading, like it's gonna, of course, have a worse prognosis, and so you could see that, 30 to 40% of non-small cell patients will already have spread outside the thorax, and 6 out of 10 of these small cell lung cancer patients will. And again, this is probably going to keep changing if we can keep rolling out lung cancer screening. This is one of these areas that more and more patients at a younger and younger age are going to have these silent small nodules. Okay. And, if you get spread outside of the thorax, the symptoms that it produces, like, this is honestly not even worth diving into because it just depends upon where it spreads. And so if you get intracranial mets, Well, that's going to make a very different symptom than if you have bony mets, where it'll cause pain most likely. Okay, that's by the way, the most common overarching type of complaint. Um, as we begin to get more aberrant, we start to present with these what are called paraneoplastic syndromes. Paraneoplastic syndromes happen in up to 20% of these lung cancer patients. And these are, like, I put a big key on here because, oh my, like, these show up on everyone's board exams. And so you really need to have at least some awareness. But then the other thing is, like, you see these things all the time. Like I do, like almost on a daily basis, it seems. So let's kind of talk through some of them. The most common one, the most common one is SIADH, or a syndrome of inappropriate ADH secretion. And so what's happening here is when we get this small cell lung cancer, 7 to 11% of these secrete ADH, and it's not secreting that ADH because of this thing that's happening in the serum osmolarity, right? Normally, ADH should rise with the serum osmolarity. As the serum osmolarity goes up, the ADH secretion goes up, and that's not what's happening here. In this case, this tumor is just releasing ADH completely independent of the regulation of the serum osmolarity. And so what happens is we develop this like euvolumic to actually, in some cases, hypervolumic state. And when we do our studies, our urine sodium remains high and our urine osmo remains high. Remember, urine sodium is a marker for volume regulation. And that's giving us insight into like things like the renin-angiotensin system being activated, right? So when the urine sodium is low, it tells us our volume status is low, our RAS system is on. But when our urine osmo is high, it's telling us our ADH system is high. So you could go back and review, I obviously, went into a lot of detail. If you have questions, if this is confusing, I'm always happy to talk through this again, because I'm well aware, to be honest, this trips everybody up. This certainly is, it takes a lot of, I think, seeing it and thinking about it to feel super comfortable with this. Next, we have what's called ectopic Cushing syndrome. So in a related lecture, we talked about this in great detail as well. And this is, again, a small cell lung cancer, and you can see up to 10%, 2 to 10% of these, they release ACTH. And again, this ACTH release has nothing to do with the regulation that's happening with that HPA axis. And so this is not Cushing disease, right? Cushing disease would be that intracranial, typically micropituitary adenoma. This is not that, right? This is outside of that CNS system, and it's ectopic. It's in a site outside. So it causes still the same symptoms, right, of hypercortisolism. And so we see central obesity, we see hypertension, we see a fat pad and the big striatiform. And again, if this is murky, feel free to ask me about this. This axis, and well, maybe the calcium one, but this axis is certainly complicated, just like the renin-angiotensin system is. Just like the calcium, regulation pathway is. None of these things are simple and easy, and I think it just takes repetition. So if it's confusing to you, don't worry, it's confusing to everybody. Next, here's one that is both tested and is a common one. So humoral hypercalcemia of malignancy. So this is a big difference. Maybe I should have put another emoticon or emoji on this slide to really highlight this, because in this case, we're no longer talking about small cell, right? So far we talked about ectopic Cushing's and SIADH. Those both happen with small cell. And right now what we're talking about is squamous cell carcinoma. Squamous cell carcinoma can release a parathyroid hormone related peptide or protein. And so this is like this ectopic production of PTH. And so it's not true PTH, but it's what we call PTH related peptide or protein. Okay, PTHRP. So these patients, because of all this PTH release, again, that's like, oh, this is a really complicated pathway. They can present with hypercalcemia, which can cause fatigue, altered mental status, weakness, other things. And so if you're seeing these types of symptoms, like of hypercalcemia, this is, when we have a lung cancer, this is what we start to suspect, right? Because this lung cancer is generating this hypercalcemia. And by the way, that's not the only mechanism, right? If we get a MET into the bone and we start to get that, erosion of that normal hydroxyapatite crystal that way, then we also can release more calcium. And so there's more than one mechanism at play there. So those are the types of symptoms that people present with. What puts people at risk? Well, of course we know that, the prevailing risk factor for lung cancer development is cigarette smoke. Okay, this should not be surprising to anyone listening to this. Anyone that has smoked, more than 2 packs per day, these current smokers, they have a significantly elevated cancer risk, right? So you can see, 1,200 per 100,000 person years. If you compare this to people that haven't smoked, so for these definitions, never smokers are typically defined as, smoking fewer than 100 cigarettes in their entire lifetime. And so in this case, you can see it's a dramatically lower rate of lung cancer. Okay, so just by itself, cigarette use really accounts for up to 90% of lung cancer. There are other risk factors, things like prior radiation therapy, maybe this person had lymphoma or something, or whatever. Pulmonary fibrosis seems to be a specific risk factor of its own, and it greatly increases the risk of a lung cancer. And then there's other things, having alcoholism, having HIV, having an exposure to asbestos. All of these things can cause increased risk of various types of lung cancers. This is not a specific thing. And why do we keep talking about this? Well, lung cancer, is not the most common, but it certainly accounts for the most death. Lung cancer accounts for 26 to 28% of all cancer-related deaths. It accounts for twice as many deaths as breast or prostate cancer. Okay? This is a crazy high. I mean, you could see that, for the prevalence of this, the mortality is much higher. Lung cancer related deaths are higher than the next 3 common types of cancer combined, right? So you could see that prostate, colorectal, and pancreatic cancer. And part of this, yes, has to do with the spread. This is also why pancreatic cancer, for example, is so high in mortality. But it's not as prevalent, number one. And number two, these cancers, yes, they're often caught when they've spread really far. But even then, even when these cancers are caught early, in many cases, the outcomes are still below where they need to be. And so this is an area where there's a lot of research being done, and this is where things are changing. Okay? This is a different kind of look. And so what we're looking at here is in prevalence. You can see here's men, here's women. And you can see this is prostate, this is breast, and this is the x-axis is the year it was diagnosed, from 1975 up to 2009. This data was published in 2013. And you can see that lung cancer incidence has been steadily going down. Okay, like here's prostate staying about the same, but like lung cancer prevalence in women has gone up a little bit, and that's just because of social habits that have changed. Like women have become more likely to be cigarette smokers, and so there's still a lot of ground that has to be worked. Um, Regardless, even though it's not the number one in prevalence, lung cancer absolutely accounts number one, not just in the U.S. but worldwide, for cancer-related deaths. Now, once we diagnose a lung cancer, we use this different staging system. So non-small cell lung cancers are staged using this familiar TNM system, tumor node metastasis system. And the small cell lung cancers actually use this different thing. They use this Veterans Lung Study Group definition, which confines, which just defines it based upon its spread. If it's limited to the hemithorax that it was found in, then it's called limited, and once it's outside of that, then it's called extensive. In some cases, the TNM system is also used. I don't know that you would be expected to do this. It's just that this is how oncologists define these types of cancers, and the TNM system is integral to understanding the stage of the cancer itself. So, to diagnose somebody with lung cancer, we need a biopsy, right? Like, it's not enough to just look at an image. And there's many different ways that this can be done. The most commonly used at this point, in most cases, is a bronch with an endobronchial ultrasound. That's what EBUS stands for. And this is helpful because that bronch with the EBUS, it also allows for sampling taken of any mediastinal adenopathy. And so we get both the initial diagnosis, but we also get staging right at the same time. We also have other options, like we could do a CT guided biopsy, but that doesn't allow for that same node sampling, and it comes with different risk, and this is a kind of nuanced conversation. Just suffice it to say that the most common thing is to have a bronch done, and typically with a bronch with endobronchial ultrasound. Now, in addition to this, there's lots of other things that these patients need. They need pulmonary function testing, they need a 6-minute walk test, and they need lots and lots of other, but those are the kind of the big things, right? They need a metastatic workup, right? They need a PET scan with the CT to see, are there lesions anywhere else? Has this already begun to spread? Okay. In many cases, patients with lung cancer may have an initial presentation with pleural effusion, and taking a pleural drainage, right, with the thoracentesis like we talked about, can really be useful because it can be diagnostic in up to 74% of these malignant effusions. And this is, we kind of talked about this before about, the first time it was like 60%, and then you get another 20-30% or so. And then beyond that, you're not getting like much diagnostic value, in subsequent TAPs. And so there is kind of a lot that we do and a kind of specific sort of workup that we go through. And suffice it to say, when you drain, anytime you drain a pleural effusion, you should be sending for cytology. If you suspect that it's a malignant effusion, you need to send at least 60 mLs of fluid. Okay. All right. Next, this whole thing about surveillance. So this is where things have really begun to change. Okay, and so historically we might have thought about using these chest X-rays. The chest X-ray has no role in surveillance or in screening of these patients that are high risk for lung cancer. Right? They have no bearing in any of this. And so what we use now are these low-dose CT scans, screening CTs, and these have actually been shown to reduce lung cancer-associated mortality. Okay, so this has really been changing things. You can see this is a fairly recent paper, 2011, and the guidelines changed, even since I've been practicing. And this is now what I would say is the gold standard, right? It's like a patient who is between 50 and 80, who has a 20-pack year history, and they're either still smoking or it's been less than 15 years, they need a CT. And notice it's an annual screening low dose CT. Okay? Don't need contrast, don't need that. You just need to see the lung parenchyma. We're not trying to look at the pleura in this case. So, pretty much everybody agrees. American College of Surgeons, ACCP, USPSTF, they all say do this yearly low dose screening CT. And if you are curious, should I send my patient or should my patient get it? They want to look. There's this link. It's pretty good, right? You can input your specific risk factors and it gives you an idea. This is your risk of lung cancer. You're low, intermediate, or high. This is an example of, I put a sample patient in just to see. Okay. So, by screening, we're improving outcomes, right? 20% relative decrease in lung cancer deaths, right? That's a pretty good payoff. There's 3 fewer deaths per 1,000 patients. You screen 1,000 patients, you'll save 3 people from an early death, okay? So that's a good website. And then this question about treatment is kind of tricky, honestly. Like, for the most part, these non-small cell lung cancers, they're kind of the same. If you catch them early enough, like they're stage 1 or 2, then they could be resected. And this is one of the big areas that things are changing now, is that more and more, increasingly more of these are caught in increasingly younger patients. And so, they may be a candidate for a very short interval or even during the bronchoscopy to have a lobectomy, okay? And so that entire cancerous lesion is removed, and that really changes outcomes for people, okay? And you can see there's other things that are offered. Adjuvant chemo, radiation, it kind of all depends. This goes beyond the scope of what we need to talk about, right? In some cases, they can't resect it, so we do this like CyberKnife, and maybe we do palliative chemo. Now, that's non-small cell. Small cell lung cancer is typically metastatic by the time it's diagnosed. Like, the thing that's different, though, is that small cell is typically very responsive to systemic chemo and radiation. And so surgery is really not an option because in small cell, it's already spread, right? And so, like, trying to do a surgical resection is like not worthwhile once it's already, been widely metastatic. And so that's kind of generically some of the options. That just depends a lot. So in the realm of lung cancer, preventing it is by far more important. All patients that are smokers should get some sort of, tobacco cessation. And this whole thing about diagnosis is important, right? So here's an example of these non-small cell patients, and their survival is heavily dependent upon what stage is it at. Now, stage 1A, right, their 5-year survival is very good. At stage B, it's already taken a huge hit. And by the time you get all the way out to stage 3B and 4, you can see the survivals out to 5 years are, pretty dismal, to be honest. Small cell lung cancer, it really depends. Is it limited? Is it extensive? And, you can see that pretty much all of them, whether it's limited or extensive, the survivals are really kind of poor on either side of these things, okay? So there's just one last look, right, at the mortality. So here is the mortality rate in men and women, and you can see here's the years. It ends in 2009. And here is lung cancer, by far the highest mortality for a long time. And you can see that lung cancer surpassed breast cancer, right? And I think it was 85. Doesn't matter. But you can see that it did start to drop, but still, the mortality of lung cancer is significantly above the others. So, lung cancer is the second most common type of cancer. It accounts for the most cancer-related deaths, and most lung cancer is attributable to tobacco, cigarette smoke. If you're doing a physical exam and you see a patient has finger clubbing, that's a sign of chronic hypoxia. Make sure they don't have lung disease. Make sure they don't have lung cancer. Okay? So that is lung cancer. Now on to something that's quite a bit trickier, and that is lung nodules. Lung nodules are just really any, at least partially solid lesion that's in the lung, and you can see here it's defined as being less than 3 centimeters or less than 30 millimeters. And once it's greater than that, we just call it a mass. Okay, any lesion that's bigger than 3 centimeters tends to be a mass, tends to be malignant. Now, there are benign growths that can get that big, but typically those are like far less common. Okay, most lung nodules are completely asymptomatic. Sometimes these might be infectious in nature, and maybe they have some sign or symptom of some infection. There's lots of possible ways these things can come on, but lung nodules are super common. Even if they're found only on 0.2% of chest x-rays, that's a useless stat, right? There's so many chest x-rays are done. Almost everyone comes to the hospital. And when you go to get a scan, this is why we always weigh the risk and benefit. This is why doing a diagnostic procedure or workup is not risk-free, because you start to discover things like this in addition to exposing them to radiation. And maybe we're compelled to do a biopsy we didn't need to do. And so, we can have complications with that. So the incidence of malignancy overall in those nodules, look at this impossible stat, right? 10 to 70%. How useless is that? And that's just because it just depends a lot on how it looks, where it's at, the clinical context. And so, is it significant that they have a nodule? Probably not, really. And so that's really the question. It's can we find these types of benign nodules, like, say, an infectious granuloma, okay, a hamartoma? Now, once a lung nodule is seen, right, the first thing you should always do is go back and look at old scans, right? Was that thing there before? And for anything that's indeterminate, then that you see on a chest x-ray, we should always be doing a CT scan, right? It's, to be honest, not common to see a nodule on a chest x-ray, okay? There's lots of ways that we can describe a nodule, and some of the things, the characteristics of the nodule itself can have an increased risk of malignancy, okay? So, for example, if we have something that has a spiculated border, like right here, these spiculated borders are really showing this aggressive kind of growth where they have these linear little strands that are projecting out. So you can see, it's almost like these little dendrites are reaching their little grasp out. They're growing really quickly. That's what it's showing you. Next is if they have what we call scalloped borders or cavitary components. And you can see that, in some cases we see these scalloped portions. We see little cavitation areas. Those are all concerning, right? That's not a benign lesion kind of characteristic. Now, when something has really smooth borders, it doesn't look like it's been growing, and it's filled with calcium deposits, that's probably an old granuloma, and that's probably not clinically significant, okay? Now, what matters is a bunch of things, how big is this nodule, how much is it growing, and what is that patient's risk of lung cancer, right? And what I mean by that is, do they smoke, okay? Now, a malignant nodule, a solitary nodule, see, there's only one lesion. They typically double somewhere between 20 and 400 days. Okay, and that takes 26% increase in the diameter. When it's doubling greater than that, those are typically benign, right? Like, yes, there are slow growing cancers, and like probably we're going to screen that person still. But for the most part, that is not what we expect of a cancer. And then when we get these inflammatory nodules, their doubling time is typically less than 20 days, right? They're growing very quickly. And so when you do see stability, like any nodule that's stable for 2 years, that's benign. Okay. Really small nodules, they have a very low risk of malignancy. Really big nodules have a much higher rate of malignancy, obviously. That kind of makes sense. There's lots of risk factors, though, and so we kind of touched on most of them. The biggest one is obviously smoking, right? But there's other things to consider. By the time that thing is over 2 centimeters, the risk that there is a malignancy is super high. Okay, you see over 80% risk malignant. Big indeterminate nodules and these patients that are like low risk, we might even just do a PET scan to see, is there other stuff? Is there, uptake? Is there something that's FDG avid in there? There's kind of different ways. This is something to refer somebody like, and even now we have like specialty conferences where radiologists, surgeons, and our pulmonologists and then oncologists all get together and look at these images and scans and talk about the patients to make recommendations. When the pretest probability is high enough, though, like in a smoker, then we might either say, well, let's watch this thing, or we need a biopsy right away. Once it does start to grow on that serial image, though, then we pretty much move to doing a biopsy. And in some cases, like we said, we just do that right away. Okay. Now, lung nodules are also very common as a metastatic lesion. So somebody has breast cancer and then all of a sudden they get lung nodules. That's pretty concerning. The lungs have a huge vascular bed, and so once something is metastatic, the lungs are a common place for them to end up. And like, yeah, this is true, the bladder and colon and breast, but those are just common types of cancers. Anything can metastasize into the lung. Okay, so lots of different things can a benign nodule be, like infectious things like old histo, or like an old bacterial abscess, maybe say something like a hamartoma or a lipoma. These little AVMs that can be in there. And then we also talked about these things like, GPA, granulomatosis, polyangiitis, rheumatoid disease, sarcoid. These can all make these nodules. In most cases, we just do these serial scans. Okay, we say let's just watch this and not move to a straightaway biopsy. And then, yeah, most nodules that we see on these CTs, they won't even be visible on the X-rays. Okay, and so, how often do we screen is a really maybe even more nuanced answer or question than it seems at first blush, right? You start to scan somebody too much, and not only are they going to have excessive radiation, but you're going to start doing unnecessary biopsies, and you might cause unnecessary worry for your patients, right? Or you might give them false reassurances. And so, there's kind of a lot that we do, okay? There's lots of various types of infectious workups, right? Like, maybe I check a Fungitel, maybe I check a urine histo, and like, I don't order all these. I order the ones that I think are relevant. And then we screen for various inflammatory diseases, like sometimes We might check an ESR, we might check a CRP, we might check a rheumatoid or an ANA or an ANCA. There's just a lot that's happening here. And this is all very patient specific. Maybe we think there's a septic emboli and we check blood cultures and a TEE. And yeah, again, like sometimes we just go straight away and we biopsy. But what we're going to kind of talk about are these things called the Fleischner Society guidelines, because these are the things that really dictate, well, what do we do with a lung nodule? And this is a part of this medicine that is really changing. This was true. And to be honest, in my practice, we don't really follow Fleischner anymore. And that's because the biopsy accuracy has changed in the last couple of years, where a lesion that was previously not possible to even biopsy it can now be biopsied safely and accurately and give a good diagnosis. And when you do that and say you biopsy a little 6 millimeter nodule, that can have pretty dramatic impacts upon that patient's 5-year survival. Okay, so when you go to look at Fleischner, like this is, I think, true for pretty much anybody, right? It's like if you see a nodule and you don't know what to do with it, this is a good recommendation to follow, right? I would say now that it's increasingly important to refer these people to like a high volume center that does the types of specialty biopsy that I'll tell you about, okay? But when you do Fleischner, this is for patients over the age of 35, and it's only for people that don't have cancer, right? So like someone that had a breast cancer or somebody who has HIV, these do not apply to them, and those patients, they'll need a biopsy much sooner, or maybe something else, like maybe they need a PET scan, for example, okay? And what Fleischner does, just to say it very plainly, is like basically as long as there's a risk of cancer over 1%, then it is recommending at least considering another scan. So, like for example, if a single solitary nodule that's under 6 millimeters, you can see that even a high-risk patient is just an optional follow-up at a year, okay? And as they get bigger, then the interval of the follow-up, it shortens. So now it's saying like, yeah, a high-risk patient, they should get a scan at 6 months and then a scan at 18 months, something like that, okay? Yeah, there's wiggle room here. There's lots of different things. I don't think that it's relevant to memorize this. I think what's relevant to memorize is that if I see a lung nodule, Fleischner is going to give me good ideas, okay? If there's more than one, then typically we look at the most suspicious one, and based upon the size of that most suspicious one, maybe the most suspicious one is like a whole centimeter. Well, then we're going to do things very quickly, right? That's very different. These subsolid nodules, they're kind of their own little category here. And again, if they're small, then we typically don't do anything. But this is like where I was beginning to allude to this, is like this whole optional CT at a year, somebody, or 6 months or whatever, when a nodule is in this range, this can now be biopsied, actually, in some cases, not all. And so it just kind of changes this will change eventually. And so I would refer people to pulmonary quickly, okay? So this is an example. So historically, bronchoscopy is done where the bronchoscopist is holding the instrument and navigating it down the airway. Well, now by using, this is like the cousin of the Da Vinci robot that you guys may have heard of before. Well, that allows navigation into very distal airways with very small bronchoscopes, and it allows very accurate navigation to the lesion and biopsy of it. And so the yield of it is very high and the accuracy is very good. And so there have even been cases that we've done, they're kind of the exception, but where they go for a single event of anesthesia and they get first the robotic bronch, and then that sample is handed to a pathologist. The pathologist diagnoses the cancer, and then they go straight into a lobectomy, which is pretty wild. That process might normally take, 6 to 9 months, right? Back and forth and getting the test results. And they go under anesthesia, and then they come out and say, you had cancer and we've removed that portion of your lung. Okay? So, what do we do? Well, you see a nodule and you've got to take a good history, right? Can we look at old films? And then we start to think, is my patient hypoxic? Do they look like they've had an infection? Are they having hemoptysis? Have they been treated recently? Are you looking like you're losing weight and having night sweats or, on steroids? Just all this kind of stuff, right? There's a lot of questions we could ask here. And if they've had a CT before and it's not been changed for 2 years, then, that's benign, right? You don't need to do anything else with that. But if you see that it hasn't, like maybe it did change somehow, but it has benign calcifications, most likely you don't need to do anything. Now, the other thing is if they're young, like really young patients, and they don't have other medical problems like, say, HIV, then again, it's probably not something significant. But, like, for example, if that's not true, or if you don't have anything, then we start to think like, okay, or assuming that they're over 30, then we start to say you're either low risk or high risk. And the high risk patients are those that are smokers. And when they are, then we start to look at these Fleischner Society guidelines, and we get them in to see oncology, and we address their underlying lung disease. Lots of stuff to do there. Okay. All right. Next, hemoptysis. Hemoptysis is expectorating blood from the airway. And this is an important diagnosis to make and to clarify, like, this is not, for example, hematemesis. Hematemesis is like when we're having it come from our GI tract. Let's assume that it is hemoptysis here. And the first question that I'm really trying to clarify for myself is this what we call massive or non-massive hemoptysis? And there's not a good agreement in the literature. And so regardless, if you've coughed up more than 600 cc's of blood in the last 24-hour period, that is a massive event of hemoptysis. And that kind of maybe changes things. But that is by far the exception. We very, very rarely see somebody have that degree. It happens, and it's usually quite dramatic when it does. Hemoptysis is typically sudden onset, or not typically. It can either be sudden onset or it can be progressive. And so it's really important to clarify that. And because when people say, I coughed up blood, well, that can mean a lot of stuff. And so this is where, starting to ask very specific questions about, okay, how much exactly are you talking about? Is this a teaspoon or is this a tablespoon? Have you been having this go on for 6 months? Are you having fevers? Like, what's going on? Have you been losing weight? Do you have purulent sputum? Do you have chest pain? Like, are you hypoxic? Are you immunosuppressed? Have you had surgery? Have you ever had a PE before? Do you have lung disease? Are you a smoker? Or, do they have clubbing? Do they have signs of a collagen vascular disease, like joint effusions? And make sure to clarify, like, is this hemoptysis or is this hematemesis? Okay. Now, the etiology of these things is typically, when we have hemoptysis, is an infection. Okay, the vast majority is, and this could be something bacterial like strep, or staph. This could be, fungal, TB, viral, whatever. Any kind of infection down in the airway can make us have some expectoration of blood. We can get cancers. We can, get other, types of insults. And so there's lots of things, right? Like infections and cancers. Bronchiectasis is another common thing. Vascular diseases, vasculitic things. And so there's just kind of a lot of stuff that can make this happen. And most of this, to be honest, is not significant, okay? But when you start to see hemoptysis, there's a few things to do. Number one is to get labs, right? Like, I want to see a full CBC. Like, do you have a leukocytosis? Maybe you have a thrombocytopenia. I don't know. Like, there's lots of things that could be at play. I want to see a full CMP. I want to see, what are your coags like? I want to get a sample of your sputum and send it to see, can I culture something? If they haven't had one, which they probably have at this point by the time I see them, they need a chest x-ray, okay? That alone will diagnose the cause in over a third of cases. If that's not the answer, then they need a CT with angiogram. CT angiogram will be pretty good because it'll tell us the answer in about 2 out of 3 cases, okay? Occasionally, when they're really unstable, we intubate them and we do a bronch right away, and that's really not for much besides to look and see like, oh, that's where the bleeding is at. It's probably counterintuitive, right? Because it would think like, okay, if we go down in there, we can make it stop. And there's not a lot of great things to do down there actually like that. You can see bronchoscopy really only identifies the cause in maybe 8% of the cases, okay? And so, of course, we want to type and cross-match. We want to follow the H&H's. We can see, do they have some sort of autoimmune disease? And then here's some good things to do. You can take the patient and put them in a lateral decubitus where the good lung is up. That's a good way to think about that. And once we do that, we can reverse coagulopathies. We can start to get blood, correct. Okay, you need platelets, you need cryo, whatever. You need antibiotics. Maybe when we do the CT angiogram, I can send and see that you have a brisk bleed that can be embolized in IR. Well, that would be great, okay? And then occasionally we can do this endobronchial tamponade. That's so rarely done. And then finally, CT surgery occasionally might have some role, but it's still on the table, right? Like maybe they have an ABM and something needs to be done, okay? Now, that's the basic workup that we kind of talked about, and we talked about this distinction, massive and submassive. When they're massive and unstable, they might just need to get intubated, right, and have a bronch done. But if they're stable, I would give them a CT angiogram. And then if they crump, then yeah, we can do these other things. Next, we have these non-massive bleeds, which are far more likely. The basic question that we ask ourselves is, do they have signs of pneumonia? Because if they do, then it's probably infectious. Treat that pneumonia, follow up, get a chest x-ray, maybe get a CT, it just depends, okay? So that is the material. These are now these summary slides for carcinoid and different kind of lung cancer. So you go to see this patient. They have renal stones in this lung mass. If this is cancer, what do you think this is? Okay. So this is, of course, a question about hypercalcemia of malignancy, because in squamous cell, we get this PTH-related protein or peptide that produces renal stones from hypercalcemia. Okay. Which of the following is the correct thing to say about screening for lung cancer? And again, this is when you're over the age of 50, you go for a yearly CT scan, 55 to 80, right? And again, once it's been 20 or 15 years since they've quit, then we don't need to go anymore. Okay. Ooh. Well, I clicked too fast, but we all know this now, right? It's like you see an incidental nodule, and the answer is Fleischner Society. Okay. Paraneoplastic syndromes. Paraneoplastic syndromes are associated with, lots of lung cancer. And which one of these is associated with squamous cell? I did this one twice because this shows up all the time because it's the exception to the rule. Okay? So when you get tested on this, I would not be surprised if you get tested on this. Okay? So my goal was to go over, give you this introduction, lung cancer, hemoptysis, and lung nodules. That's a typo. Lung cancer has the second highest prevalence of all cancer, but the number one mortality. Don't forget about the screening. Use that Should I Screen tool. Look at Fleischner Society guidelines. That will give you the insight into when do you follow up. We classify lung cancer as either small cell or non-small cell. Typically, small cell is metastatic on diagnosis. There's lots of paraneoplastic syndromes. Most paraneoplastic syndromes are associated with small cell lung cancer. Okay? Little bitty lung nodules typically don't need to be followed up. When you see a bunch of them, you look at the most suspicious one. And don't forget, there's lots of unaddressed underlying lung disease in these patients. So like maybe they need COPD treatment, maybe they need oxygen, maybe they need pulmonary rehab, I don't know. Okay? And so refer them to pulmonary, refer them to oncology early. Okay? The most common cause of hemoptysis is infection, and be specific when you see a hemoptysis patient, right? How much are you having fevers? Is your sputum purulent? What's the frequency? Is it happening once an hour? Is it happening once a day? Once a month? Stuff like this. Okay? So if anyone has any questions, feel free to let me know. Here are some particularly useful resources that I found. And if you have any questions, feel free to reach out to me. Thanks again for your time, and I'm looking forward to our next discussion.